and bring to the stage Joe Berger, Vice President and General Manager for Health and Consumer Solutions at Battelle, and Dr. Wilson Compton, Deputy Director of the National Institute on Drug Abuse.
So we've heard a lot of statistics this morning about the opioid problem. And I live in Ohio, and we have the unfortunate honor of leading the nation in this problem. In fact, I was driving to the airport yesterday and heard the most recent statistics on central Ohio, which is mostly urban and suburban, and that the opioid deaths are on track to go from 350 last year to 500 this year. So we continue to be faced with this problem. And so now the question is what can we do about it? So today I'm joined by Dr. Wilson Compton, Deputy Director of the National Institute on Drug Abuse, to discuss evidence-based treatment strategies to reduce the number of people developing addiction problems and to treat those who become addicted. So Dr. Compton, thanks very much for joining me.
I'm glad to be here today.
So let's start. What are some of the biggest areas of progress we've made in stemming the tide of opioid addiction? We obviously are making some progress, but we still have a long way to go.
Well, I think you've just reminded us that even as we are making progress in a few areas, the number of deaths overall continues to increase. And that has every public health official and every policymaker concerned. So how can we do a better job of addressing this public health crisis? We do see some improvements in two areas I want to highlight for you. One, and we heard this from some of the earlier speakers, that the overall number of prescriptions written for opioids has begun to decline. It leveled off starting in about 2012, and we've seen a reduction in the physician's willingness and overall overprescribing of these medications. That's a little bit of a hopeful sign, but we need to do a better job, not just level off, but actually decrease the number of prescriptions significantly. The second hopeful sign is we've actually seen a terrific improvement in the recreational or illicit use of these medications by teenagers. About 10 or 15 years ago, we saw that about 10% of 12th graders were using a prescription opioid or misusing it for its intoxicating properties. They wanted to get high and they were using these medications recreationally. That number has dropped to under 4%. So that's a terrific improvement. And this is the future of the field. These are the people who will go on to misuse during their early 20s and really develop the serious problems that end up with the addictions and deaths that we're seeing now. Great. So I think that's very hopeful.
Good. I'd love to dig into that more, but let's talk about, we've heard this morning about medication-assisted treatment a lot, so I'd like you to talk a little bit about what that is, maybe for our audience who aren't as familiar with it as some.
I think it's a great question. You know, what is medication-assisted treatment? Well, basically what that means is that it means using a prescription medication to combat the disease of addiction. We're very lucky in this field of opioid use disorder, opioid addiction, that we have 3 FDA-approved medications. We've had methadone for about 50 years in our country to treat people who are addicted to opioids. We added buprenorphine just a few years ago. And we've had naltrexone both in its oral form for a number of years, and then more recently we had a long-acting version of naltrexone. That's a blocking agent. So these come in 2 different classes. Buprenorphine and methadone are both medications that substitute for opioids and allow people, when dosed properly, to enter recovery, to get back their functioning and save their lives. Naltrexone has sort of the opposite effect. It blocks how opioids work in our brains. And so it's a blocking agent. And now this new formulation can last as long as a month with a single injection.
And are you seeing, so are there trends? Are some of these becoming more popular? Are some of them being used less? What's happening in that area with these 3 different treatments?
Well, of course, we'd like to see these medications be available to every patient that needs them everywhere in the country on demand. That's actually our goal, and that's the goal of all the public health system, is to increase the availability so that if you or a loved one has a problem with addiction and you go to your physician or you show up in an emergency room, they can get you treatment on demand. Unfortunately, that is not the case. We have seen increases in both methadone availability. These have to be in specialized methadone treatment programs. We've seen increases in buprenorphine prescribing because we have greater number of prescribers, and due to changes in the rules that our colleagues at SAMHSA implemented, we see an improvement in the number of people that clinicians can treat with buprenorphine. We also see increases in the availability of the long-acting naltrexone injection. But despite those improvements, there are tremendous barriers in many parts of our country and a lack of educated clinicians to take care of patients that need this care.
Yeah, so what are some of the policy issues? What's keeping us from getting it more broadly available to patients who do need it?
I think we've heard this theme already this morning, that the fundamental issue is the stigma around addiction. That we've spent way too long thinking of addiction as purely a moral failing and a decision making. So you're making bad choices, just quit doing that, is sort of the message people get. If it were that simple, all of my patients and others who have addiction would have quit long ago. They suffer tremendous harms, and yet because of the compulsive behavioral origins of this condition, they keep engaging in the behavior. That's why we need effective medications that can combat it, and I think forums like this that help educate the public and others about the medical nature of this disease can really make a big difference.
So we both live in the research world, so let's talk a little bit about some of the research you think that needs to be done in this area, and maybe talk a little bit about some of the research that you're doing at NIDA these days to help us understand the problem better and help us address the problem.
Well, of course, I'm very proud of the work we're conducting at the National Institutes of Health, and particularly at the National Institute on Drug Abuse, to try to address this public health crisis. I sort of put the research in two main buckets. One is we have treatments that have effects. We have treatments that are useful. We have prevention approaches that can provide communities and families the tools they need to raise healthy children and keep them from moving into the addiction sphere. So why are we implementing these widely and universally? That's sort of a key research question. What can we do to improve the access and availability of the current treatments? Now, as much as I like our current treatments, and I'm thrilled that we have multiple approaches to prevent and treat these diseases, they're not as effective or as good as I would like. I would like something that was perfectly effective. I'd like something as good as ampicillin for an ear infection, where you go to the doctor, you have a sore ear, you get the medication, and you're better. That's not the case with our addiction treatments. They work, they help people, but they only help a minority of the people that start them. People stop their treatment. This is a long-term condition, and yet people often don't take their medications as long as they need to benefit from it. So these are some of the issues where I think research can provide tools that can be the solutions to these long-term problems if we invest in research successfully.
And so we've talked a little bit this morning about how this really is a bigger rural problem than maybe an urban problem. So what are some of the ways that maybe we can help that rural community access some of these treatments more effectively? I mean, it's probably, we've heard it's much easier maybe to put this in an urban setting, but what about the rural settings?
It's not just limited to addiction. We struggle to get health care to rural populations across a range of issues. If you need a cardiologist and you live outside a major urban area, it's really difficult to access that care. We have addiction specialists in many locations. We have family doctors in more locations. But there's some parts of the country that don't even have access to general medicine or family medicine. So what can we do to use telehealth? What can we use to use part-time practices that may come into these locations? What can we do to get nurse practitioners, physician assistants, other forms of care that are part of helping people enter recovery in all the regions that need them? Can we use the internet to provide care long distance? Some of that has been shown to be possible, but how can we do that on a more widespread basis? Research can help with that, as can the new funding that we've seen with the 21st Century Cures Act and other novel ideas that the states and local areas are coming up with.
So you got a little bit ahead of me there. So what public health policies that have been implemented at either federal or state or community levels even do you see having a positive impact other than maybe the Cures Act?
Well, there are multiple policies and practices that need to be implemented. What can we do to change the availability of medication-assisted treatment, for example? Some states still have regulations that require to fail non-medication treatment before you can even start medications. That seems counterintuitive. As a physician, I want my patients to have access to the effective medications when they have the problem and not have to fail some other ineffective approach before they can take what might help them. That's just one example of policies that can change. When it comes to the provision of naloxone, we heard Dr. Wen describe how she's written a prescription so that everyone in the city of Baltimore can gain access to this life-saving medication. There are certain states and locations that have done that in other parts of the country as well. but that's not universal. So what can we do to make sure that this immediate, life-saving, non-addictive medication is universally and easily accessible when people have an overdose? In those libraries we've been hearing about, which is really a remarkable story, or in other places where people may experience this death.
So Dr. Compton, thank you very much for joining me this morning. Thank you to our audience for coming today, and to the Washington Post for focusing on such an important public health issue. I also encourage you, after the speakers are done, to talk to our subject matter experts who are outside. And now it's time to turn it back over to the Washington Post for the next discussion. Thanks.
Thanks very much.